So good evening. We will go ahead and get started and wanted to welcome you to this conversation about the COVID-19 vaccines in our community, and really hope that this will be an information session where you'll not only hear from experts across Johns Hopkins Medicine and our Johns Hopkins School of Public Health, but we'll also have an opportunity to get some of your questions answered, and even to also hear from some of our medical experts, what things have motivated them in terms of their decision-making around the vaccines. We also want to help you understand why some of our communities want or feel they need more information so that they can make informed decisions around the vaccine. So we'll cover some of that information as well. And I'm really excited to be joined by several colleagues, and I will introduce each of them to you as they present their overview. So I'm going to start first with just, I'm going to share my screen for a second and just start with an overview and sort of informing our thinking around vaccines. And so I think it's really, let me just put this in view mode. I think it's really important to sort of reframe COVID-19 vaccine hesitancy. Really more is just the need for vaccine education and access so that informed decisions can be made. So I'm Dr. Sharita Golden. I'm the Vice President and Chief Diversity Officer for Johns Hopkins Medicine, and I direct the Johns Hopkins Medicine Office for Diversity, Inclusion, and Health Equity. And so, we feel that an important part of our mission is not only to educate our employees around issues that impact their health, but also to support efforts to educate the surrounding community. So one of the things I think is important is to really understand why it is that there are certain communities that have mistrust of the healthcare establishment, because that can help us in determining how to approach the education around the vaccine. So we know that there are a variety of medical and scientific contributors that have caused some sort of the healthcare system in some ways have violated the trust of some of our communities, particularly our non-white communities. And so it's important to think about that. And so we know that eugenics theory at the turn of the last century defined certain race and ethnic groups as being biologically inferior. And even though that's been scientifically refuted, we know that there are that thinking may still exist and bias some of our medical decision-making. In addition, there was the closure of medical schools that trained Black physicians in 1910, except for Howard and Meharry Medical College, when the Flexner report was published. And so that report said that medical education and medical schools should be done using a biomedical model and not a proprietary model. And essentially many medical schools across the US were closed, but for the medical schools that were training Black physicians and that weren't given the resources to upgrade to those standards, they were closed, except for Howard and Meharry. And this was at a time where those individuals couldn't gain access to predominantly white medical schools. And then I think importantly, there has been experimentation on vulnerable groups without their consent. This started during slavery, where Dr. J. Marion Sims repeatedly performed and perfected his gynecological procedures on slave women, not only without their consent, but without general anesthesia. And so this has led to even bias today that, for example, Black patients have a higher pain tolerance. And so when they are justifiably seeking pain medication after surgery or during a sickle cell crisis, they're more likely to be labeled as drug seeking, because there's this idea that they have a higher pain threshold, when in fact this is likely just what a lie that the doctors had to tell themselves back then to engage in what was barbaric behavior. And so as we think about those things, it was not only racial and ethnic minority groups that were experimented on, but also individuals with intellectual and physical disabilities, individuals who were imprisoned, and many of those practices didn't end until the 1970s. So there have been situations in which the medical establishment has violated the trust of those communities. There's also language and communication barriers that we'll hear about and think about. And then there's also healthcare provider bias toward minoritized patients that impacts their experience in the healthcare system. And so what results in those biases is that you end up, despite controlling for the level of education, many physicians still rate Black patients as less educated compared to their white counterparts. And then Black patients, as I mentioned, are less likely to have their pain adequately controlled and be labeled as drug seeking. And so, you know, in the healthcare professions, physicians are not biased when you have to use objective things to decide if someone has a diagnosis, but there is bias in things that are more subjective. But I think what's really important is to not let past offenses impair addressing and advocating for COVID-19 health needs. And one thing that's important to think about, and Dr. Gregory Branch, who's the health commissioner for Baltimore County, we were on a community town hall earlier this week, and he made a very important point that there is concern about getting the vaccines. However, for all of us, if we get COVID in the setting of being unvaccinated, the first place we're going to go is that healthcare system that we say we didn't trust. So really, this is a preventive measure to avoid that. And so we really need to think about and balance that, and then really recognize the impact of coronavirus. And this is an older graph from the fall, but it's just very telling that very early on in the pandemic, it became clear that Black communities were dying disproportionately from COVID-19. And then when we began collecting data in our Indigenous communities, they were also dying disproportionately from COVID-19, as were our Pacific Islander community members. And then initially, our Latinx community members were dying at the same rate as whites, even though their infection rates were higher, likely because they were getting infected at younger ages. But even in the summer and the fall, our Latino colleagues began dying at higher rates. So I think it's really important to recognize that, you know, there is still a pandemic. People are still getting infected with COVID and still dying. So it's really important to consider all of that in decision-making about the vaccine. This is data on vaccine readiness, where there was a poll across the country looking at how likely people were to get the vaccine based on age and also based on their race and ethnicity categories. And what's shown in 13 is I will never get the vaccine. And then here in the orange is I'm not sure, and the blue is I will get the vaccine, but will wait. And so you can see here that in younger populations, there was maybe a little more of I'm not sure I'm going to get the vaccine or I'm not going to get the vaccine. But interestingly, when you look at, and certainly in the older age group, there are many fewer who were questioning it. The majority of adults over 65 are going to be very likely to get the vaccine, or they had gotten it when this was taken. And then if you look among racial and ethnic groups, if you look here in the Black population, there was a larger percentage here, almost 45%, that either we're not sure or we're not going to get the vaccine, and similar statistics among the Hispanic population. So, this is sort of the vaccine readiness data. But as I mentioned, that hesitancy really may just be the need for education to information and access. And so the definition of vaccine hesitancy is delay in acceptance or refusal of vaccination despite the availability of vaccine services. That's a general definition. And delays in acceptance could be because of the need for accurate information to make informed decisions. And so that's what we want to really help to espouse today, and the availability of vaccine services. So, access has remained a challenge throughout our state. That is improving now. The age categories have opened up, and there's more mobile vaccine efforts across our state. And so hopefully the access issue is being addressed. And then there are valid vaccine concerns. This is a survey basically just showing what were the questions and things that people were worried about. And you'll see there's not much difference by race or ethnicity. And so in fact, these were the top 10 concerns that were all valid. And I will say they were ones that I had myself. So what people are worried about are the vaccine side effects. They worry that the vaccine has been rushed and will be released before it's ready, that vaccines may contain harmful ingredients, or that they will get COVID-19 from the vaccine. So we will address all of those things this evening. And just sharing my own personal vaccine story and what my why was. I got my first dose of the Pfizer vaccine in mid-January, and I had many of the same questions that you had. And as I read the information and understood that the clinical trials were rigorously done, there were no corners cut, they were done in a large number of people, I looked at the data and saw the vaccines were effective. And even though the mRNA technology was touted as a new technology, I learned and read that technology had been developed for about 9 or 10 years. specifically to be able to respond to a pandemic situation like this. And so intellectually, all of those things helped me with my decision, but I will say the heart pull were my parents, both of whom were blessed to turn 85 last year in the middle of the pandemic. And I felt like I'd spent a year just trying to not expose them and keep them alive. So they were really my most important why. And so now our family is all fully vaccinated. So this is me getting my second dose in mid-February. And we have also, across Johns Hopkins Medicine, been doing a lot of vaccine education and equity work, supporting our own employees, as well as community outreach events like the ones we're doing this evening. So just want to acknowledge the many colleagues that have worked with us on these efforts. And we also have a COVID-19 Disparities in Vaccine video series, and two of those features are speakers are featured this evening, but we'd be happy to share these links with you in the chat so that you can get more information. And we've been partnering with many of our senior housing facilities, with the Baltimore City Health Department, as well as many of our churches, to do mobile vaccine outreach efforts in the Washington, D.C. area, right here in Baltimore, and over in Highlandtown through Sacred Heart for our Latino community, which was a COVID-19 testing site and has now been converted into a vaccine site in collaboration with the Maryland National Guard. So I'm going to stop sharing now, and so I want to next introduce Dr. Agnes Usoro, who is a emergency medicine physician at Johns Hopkins Howard County General Hospital, and did her residency training at Johns Hopkins Hospital. And she is going to speak with us about COVID-19 disparities in the Black community and other considerations as they relate to the vaccine. So thank you, Dr. Usoro.
Thank you for the introduction, Sharita. I apologize if my voice does not come off very clear. As I mentioned to the panelists, I'm learning how to speak through my new Invisalign trays. But I'm going to share my screen at this time and talk about COVID-19 and the disparities that were experienced amongst the Black community. As Sharita stated, I'm one of the emergency medicine physicians at Howard County General Hospital, and I'm happy to be here. My only disclaimer is that I did get fully vaccinated, and my why was because I have two parents that both are cancer survivors, and I wanted to make sure that I was not exposing them, that they fully themselves are vaccinated, because it's early in the pandemic. It was very, very rash, the amount of individuals, particularly in the Black community, who were dying disproportionately compared to their counterparts. And so looking at the statistics of COVID-19, we know that the percent of cases of racial and ethnic minority groups are higher than the percent of them represented in the US population. We do know by statistics that non-Hispanic white individuals are the highest percentage of COVID-19 cases, but that Black individuals, despite only representing about 11 to 13% of the population, are dying at a higher proportionate rate compared to their counterparts. And a key statistic that really shocked me was that nationwide, Black individuals have died about 1.4 times the rate of their white counterparts. And that really got me under trying to figure out exactly why and why that's going on. Let's look closely at the statistics by racial group. So we know that non-Hispanic white individuals make about 60% of the population. I'm going to make this smaller in case that's covering that up. And that they, for the most part, about 50% of the COVID cases, and their death rates pretty equivalent to that at about 52%. Hispanic individuals are about 18% of the population, but just as Sharita had mentioned, we're disproportionately more infected, about 30% of the COVID cases, but their death rates were actually now have leveled off and are closer to 9 to 10%. The non-Hispanic Black individuals, though, I wanted to highlight that make on average about 12% of the population have been infected at about the same rates, but their death rate is nearly more than double that at about 35%, the highest in any other group outside of the non-Hispanic white population. And when you look at other groups, as far as like the Asian groups, the mixed race groups, American Indians and Native Hawaiians and other Pacific Islanders, they also fall less than they do compared to their representation in the population. I do think that the American Indian population, the data that I've received from the CDC is underrepresented, because I do have colleagues working on reservations who are notably noting that the infection rate is significantly high. So I think we're undercounting the infection rate amongst American Indians, but we're going to focus on the Black community where this death rate is significantly high compared to their infectivity rates, and try to understand exactly why that is. And I think overall, to kind of grasp that, you need to go back to the social determinants of health, which are kind of the key points that we recognize that health in itself is not necessarily the care that I give to you in the emergency department, or the care that your doctor might give to you in the primary care clinic. We recognize that there are other factors in your life that do contribute to your health. For example, your neighborhood and your built environment. We do know that minorities, particularly Black individuals, tend to live in more crowded, multi-generational homes, and that puts them at higher risk for spreading the COVID-19 virus. It also puts them at risk that if they were positive, they couldn't quarantine as easily as someone else who perhaps only had themselves or immediate family in the home. We look at economic stability. We recognize and are aware that a lot of the Black population were considered essential workers. They were working on the front lines in the hospitals, in transportation, in the food industry, areas at which they could not stay at home and work if they had to, because they had to go to work. And if they were fortunate enough to keep their job, again, they were frontline workers. We do also recognize that despite all that, a lot of them did lose their jobs. As of now, about 7.7 million Americans lost their jobs during COVID, and therefore a lot of them lost their healthcare coverage if they did have it at that time, and that disproportionately affected a lot of minority groups. And when we look at education, we know that the education of individuals is tied into the income and wealth gap that we do recognize is present in the United States. And so if you have a lower education, you're more likely to be experiencing a higher disproportionate wealth gap, and therefore less likely to have an emergency fund. So if you were one of those unfortunate Americans who lost your job, you more likely did not have an emergency fund to support you as you were trying to get a new job, or until the protections and the actual benefits from the federal government kicked in. And lastly, when you look at the social and community context, we do know that in minority communities, they are more poor and have less resources, and therefore couldn't handle a lot of the changes that took place with the early pandemic. And so when you look at exactly why we're trying to understand the social determinants of health and try to really get to the root of how we manage this pandemic, the ultimate goal is herd immunity. And herd immunity is essentially the point at which we have enough people in our community vaccinated so that the virus itself, and we're going to say SARS-CoV-2 virus, which causes COVID-19, can no longer propagate in the community. And so what we've decided in the scientific community to combat the COVID-19 pandemic is our goal is to reach that number of herd immunity, which for COVID is estimated to be anywhere around 80%. And so we really are trying to work towards getting individuals in the Black community vaccinated, but we may not be doing the best work or job when we look at the statistics. We know that the United States so far, as of April 28th, has put out at least 234 million doses of vaccines, which is very, very promising and reassuring, particularly looking on the global stage. Of those individuals, about 42.7% of the US population has received at least one dose of the vaccine. So again, very reassuring. But when you look at that and actually look at the vaccine rates across the United States, it is quite disproportionate depending on where you live, with areas that are being more darker being the most highly vaccinated areas, and areas that are more lighter and pink being less vaccinated areas. And when you look at it by state, particularly at the Black population, and I use Maryland as the key state since that's where we are now, we're only vaccinated about 24 to 25% of the Black community in Maryland, despite our population of about 30%. And again, if you look at that death rate, significantly higher than our population, the Black population in Maryland. You can see that in other additional states. The District of Columbia has vaccinated about 36% of the Black population, which is far less in proportion to 46% that the Black population makes up. And if you look at the death rate of Black individuals in DC, it is astronomical compared to their population representation in DC. And you see that same thing in several other states. Pennsylvania has only vaccinated about 4% of their Black population compared to the 11% that makes up the state. And so the question we asked is, why are we not seeing equitable vaccination rates? And Sharita mentioned this very well. One is just mistrust with the community, mistrust with the vaccine, mistrust with the scientific rigor that went into these vaccine production. And I think the other one is also just misinformation, not understanding exactly what this pandemic entails, the treatment options, and how we can get our way out of it. And so how we're combating that is trying to make sure that we make individuals aware that as a medical community, we've learned from our mistakes of the past of the abuse that's taken place against disenfranchised communities, but also having small discussions like this so that we can answer all of the questions to combat those misinformations that may be out there. I think if we go back to the key statistic that Black individuals are dying at a higher rate compared to their counterparts, I think that will help to at least push forward more of an agenda so that we can answer those discrete questions that individuals may have, particularly as it relates to the COVID-19 and the vaccines that are available. I want to make sure that everyone is very much aware is that we're really trying to make sure that people realize and recognize that the 3 vaccines, and this is a busy slide, these are just the screenshot of the scientific papers that each vaccine put out in New England Journal of Medicine, the top being Pfizer, Moderna, and Johnson & Johnson. The takeaway from all of this is that we know that all of the vaccines that have received emergency use authorization in the United States are effective against severe COVID-19 disease. Pfizer being about 94%, Moderna 95%, and Janssen being about 85% at 28 days. And so the key message that we want to make sure that we are putting out towards individuals of the Black community is that we are dying at a disproportionate rate and we have available treatment options that can save your life. And so we want to make sure that that message there is being put out towards other individuals. And again, the end goal is herd immunity. We want to make sure that we can nip this virus in the butt and kind of end the propagation of COVID-19. And that is important because if we don't achieve herd immunity, we eventually will get to the point that this infection becomes ubiquitous, kind of like the flu, influenza. And what we do know is that the CEO of both Pfizer and Moderna have stated that if we don't get to the point of herd immunity, they anticipate that we will likely need a 3rd booster shot or a 2nd booster shot, 3 shots total, in addition to annual shots thereafter. And so our goal is to make sure that we're educating our community to make sure that they're aware that there are consequences if we cannot get to the end goal of herd immunity. And I think I will end it there because I believe we're doing questions at the end of this session.
Yes, thank you, Dr. Osoro. That was terrific. So I next would like to invite Dr. Kathleen Page, who's an associate professor of infectious diseases in the School of Medicine, and she's going to give an overview of vaccine considerations for our Hispanic and Latinx community. So Dr. Page.
Hi, Sharita, and hi, everyone. Thank you for having me. And I'm going to give a quick overview. I think Dr. Osoro went over very nicely some of the issues affecting African Americans, and I think there are some similarities with the Latino community. So I'll quickly go through my slides so that we have time for questions and answers. So let me just share my slides and get going. Okay, let's see. Oops. Oh, sorry. Everything's coming up except what I need to come up. Sorry about that. Let's see. Okay, here we go. So as was mentioned before, especially early in the pandemic, it was really quite noticeable in our health system throughout in Baltimore as well as in Maryland, how many Spanish-speaking immigrants were being admitted with COVID-19. And certainly these are data from Baltimore City, and you can see here the infection rates by race and ethnicity. You can see this teal line are whites up to pretty much the beginning of this month. You can see the disparities here with African Americans at a much higher infection rate, and then Latinos really outnumbering everyone by quite a bit. These are data from the CDC, and really what they show is that these disparities were not only happening in Baltimore, they were happening throughout the country. And you can see here on the top row, the number of cases compared to white. So with, for example, Native Americans, twice as likely to have COVID-19 or be diagnosed with COVID-19 compared to whites. A disproportionate impact also on African Americans and Latinos. Very high hospitalization rates for Native Americans, Blacks, and Latinos, and also very high, almost 3 times the death rate for these 3 groups compared to whites. So why was this happening? And Dr. Risoro mentioned some of these issues. When I was on the wards in May and June of last year, seeing so many Latino immigrant patients, they all basically told me a very similar story. When the state here, for example, shut down, many of these low-income immigrants did not have any savings. They also, because of their documentation status, were not eligible for the stimulus check. They weren't going to get unemployment benefits. And so they had to work. And they were also, many of them in the essential workforce, either working in construction, in childcare, in the meat and poultry industry, et cetera. And so they continued to go to work. And early in the pandemic, that really created a huge storm because it was before we really knew what the adequate protections were. And so many people went to work without knowing that they had COVID-19. We, at the time, if you remember, we didn't know that asymptomatic transmission was really common. And so that really fueled a lot of transmission. The other factor that really was notable were the crowded living conditions that many people live in. And this is not just multi-generational families, which are certainly common in this community, but often people who just share housing because of need. So for example, workers who may or may not know each other well, but they share a basement so that they can actually afford to live somewhere. And so that, of course, those types of settings did not allow for allowed for a lot of transmission. And then the last thing that was heartbreaking was to hear people tell us that they were sick for a long time and many people didn't have a doctor. And so they just sat waiting, hoping that they would get better, sometimes presenting to the emergency room too late. So there's better news now, and certainly now we have learned a lot from the pandemic. And so I think that initial surge, although we have continued to see a lot of transmission in this community, that initial surge, which was quite tragic, has subsided to some degree. And of course, we have the vaccine, and that really gives us a lot of hope. The thing that's concerning, though, is that I think we've both made a strong argument, hopefully convince you that among the African Americans, Latinos, we haven't talked about other groups, but other communities of color have really been highly impacted by COVID-19. And so you would hope that these groups would also be the ones that would have the most access to vaccination and hopefully the most uptake. However, we haven't really seen that. And what this slide shows is the percentage of the population by race and ethnicity that has been vaccinated in the US so far. This is up to April 19th. And you can see that about 40%, 35% of whites and Asians have been vaccinated, but only about a fifth of Black and Latinos have been vaccinated, which is, of course, disproportionate to what you would expect given the burden of COVID-19. And I think both Sharita and Dr. Risoro really outlined some of the reasons why. I think certainly there is some hesitancy and there's mistrust, But I also think that access is critical. And I do think that it's important that we distinguish the two things. And, at least early on, access to the vaccine was really not easy for many communities, particularly low-income communities, people who had digital barriers, technology barriers, people with limited English proficiency. And so what we have found is that it's just not enough. I mean, while of course mass vaccination sites are really important, and there needs to be many ways and choices for people to get vaccinated. For some people, we just need to go to where they are because that's the easier we make it, the easier it'll be for them to get vaccinated. It's also really important that when we go to places, we don't just sort of land in a place, but actually partner with our community, have people from the community be ambassadors and really promote that trust. And so, in the Latino community in particular, there's a lot of language barriers that need to be addressed, digital divide. By going to places where people are, you can overcome some of the issues with transportation, mistrust, etc. So we've been really thankful to many people, including Sharita on this call, who was very supportive of this effort. And so early in the pandemic, the first challenge we had was that there was not enough testing or access to testing for people who had limited English proficiency, had difficulty navigating the system, didn't have a doctor, didn't have health insurance. And so we partnered with a local church and established community testing. And we've also done a great deal of work, which I think has been essential, with local Spanish language media. So for example, this is a show that we do every Friday called Ask Your Doctor, where we answer questions from the audience about what's going on in COVID-19. And so, thankfully, as you can see here, we've tested almost 4,000 people in these settings. Although the positivity rate is alarmingly high, actually, among Latinos, about 30%, and still around that level. So we've used that same space now inside, because the testing has to be outside, but the vaccination can be done indoors, thankfully, to implement vaccination at the site. And this has been remarkably successful. I think part of the reason is that there was already trust in the community about this place. They knew us from being there. We have amazing, these are Melissa Cuesta and Alejandra Flores Miller, amazing community health workers who do a ton of outreach. And so through these sites, we've vaccinated almost 2,000 people so far, and we keep on going. And so this is only to say, this is just something that I saw yesterday from the CDC, but there's many more information coming. But this was a slide saying that they've looked at real world experience with vaccination in the US and how it's reducing the risk of being hospitalized for people 65 and older. And I think we're gonna see more and more data like this for other groups. And it just reminds us that this is not something that any of us do alone, and it's important that we all work together to see how we can really get over this pandemic and help each other give the right information, good information, so that we can all make the best decisions for ourselves and our families. So thank you.
Great, thank you, Dr. Page. So next I want to invite Dr. Bonnie Sweenor, who is an associate professor of ophthalmology in the Wilmer Eye Institute and also is the director of the Center for Disability Health Research, to really talk about vaccine considerations for our communities that have various disabilities. So Dr. Sweenor.
Thank you so much for having me here. I'm gonna try and share my screen. Make sure I do this correctly. Oops, I don't think I did it correctly. What are you all seeing? Are you seeing? I think it's good. Okay.
We see your screen.
Good. Okay, good. So thank you so much for, see if we can make that go away, for having me. So as Dr. Golden said, I'm the director of the Johns Hopkins Disability Health Research Center. And since the time of COVID-19, almost all of our work has really pivoted towards focusing on the impact of COVID on people with disabilities in the disability community. Often when we talk about disability, it's important to recognize that it is a homogeneous population. It's really an umbrella term, and I'm not really sure why that's showing up, why I can't make that go away, but there's many groups that fall underneath the umbrella of disability, but there's some commonalities and some common themes of the impact of COVID-19 among everyone under that umbrella of disability. And so disability in the United States is not a small group. It includes 1 in 4 American adults have a disability. And as an epidemiologist, I can actually assure you that that's an underestimate. It's a higher prevalence than that. And that includes people with mobility disabilities, cognitive disabilities, sensory disabilities, vision and hearing. That number actually is not a great estimate of people with psychological disabilities or mental health conditions that impact daily life. And COVID-19 has uniquely impacted many people within that group, although during this time, the focus on disability, I think for most of us, has, at least at the beginning, really has been on individuals living in nursing homes and congregate care settings. That's been really important because early in the pandemic, and these are data from September of last year, showing that about 40% of COVID deaths at that time were really occurring in nursing home settings. I don't think people always recognize, but to be in a nursing home, you actually must have a disability. That's really part of the equation. And so when we're talking about those settings, we're talking about people with disabilities, not just older adults, which is what I think lots of people consider those settings to be inclusive of. This is just data, additional data from Kaiser Family Foundation showing long-term care settings, which is just a more fine definition of nursing homes, showing similar data, the unequal impact of COVID-19 mortality of people living in those settings. There's been a lot of discussion around why that is. I think at first glance, it makes sense to think that people are living in very tight quarters and perhaps inclusive of many individuals that were immunocompromised. But it's also important to think about, at a societal level, the ways in which we have not always thought about the structural barriers for people in those settings, or at least considered their rights in those settings, and those kinds of discussions have come to the forefront. It's not amiss to say that what has happened in nursing homes is not a magnification of greater issues that have occurred, inequities that have occurred for people who are living in nursing homes. It's just magnified problems, I guess is the way to say that. But as the COVID-19 pandemic has rolled out, we have been able to get data in people living in the community and broader groups of people with disabilities. There's been challenges to that data, which we'll talk about. But another group of individuals within the disability at great risk has been people with intellectual and developmental disabilities. That in and of itself is actually an umbrella term. But fairly recently, there was an article in the New England Journal of Medicine stating that having an intellectual disability was the strongest independent risk factor for presenting with COVID-19 diagnosis and the strongest independent risk factor other than age for COVID-19 mortality across a number of studies. COVID-19 mortality, the data show, is up to 8 times higher in people with intellectual and developmental disabilities than in the general population. That estimate varies between 2.5 to 3 times higher, up to 8 times higher, depending on the study. But regardless of the study, most of the data really have pointed towards a much greater risk of mortality in that population. So then the question is why? Why is that happening? Why is there a greater risk? Now, for some populations, some of these studies, it's in part because these individuals are living in congregate care settings. So there's again that compounding effect of what's occurring in those settings. But I'd be remiss to not say that there's also considerations of the impact of social distancing, the social structures put in place to respond to COVID-19 are uniquely challenging to certain members of our community, including many members with intellectual and developmental disabilities who may not be able to socially distance appropriately or wear a mask because of sensory sensitivities, increasing their risk. But beyond that group of individuals with intellectual and developmental disabilities, we've really struggled to track COVID-19 in the community of people with disabilities. It's been a problem, and it honestly remains a problem now that we're talking about vaccine rates and vaccine uptake. Disability data has often been left out of public health systems. There's not standardized ways of capturing that information, even in healthcare settings, really across the country. And because of that, we cannot track COVID as well as we would like to in this population, which we are starting to recognize is at really increased risk of severe COVID outcomes and mortality based on the data we do have. So that's been a problem, remains to be a problem. And on top of that is there's barriers to COVID-19 testing and vaccine that may magnify the fact that we don't have data tracking it. And so what I mean by that is in my work in interacting with and partnering with the disability community, I know that getting to a vaccine or to a COVID testing site can be an immense challenge for people with disabilities and creates a huge barrier. But without the data, without the ability to track and identify, we're having a hard time to target our approaches to reach those individuals. And that's been a struggle, and it continues. So some of the barriers in accessing testing, care, as well as vaccine for the disability community include challenges with information. This started at the beginning of the pandemic. A lot of the information around COVID-19 has not been fully accessible. And that creates a barrier for people within the disability community of having an equal or equitable chance at just knowing when to get a vaccine, where to get a vaccine, and information early on around the social measures or the what to do as the pandemic continues. Transportation is a huge problem and continues to be a problem for a lot of reasons. Again, disability is a heterogeneous population, and that concerns with transportation range from not being a driver because of a disability and only having drive-through or drive-up testing or vaccine sites around you, and those not always being accessible to you, as well as individuals that use paratransit and mobile transit services. There's barriers around scheduling those, the safety and the precautions taken in those settings for people with disabilities to get to care or to vaccine. There's a lot of concerns in transportation. Accommodations, I think, is one that isn't always discussed, but accommodations at vaccine sites is really important. So for a lot of people with disabilities, they may need to have an interpreter. If they're from the deaf community, they need large print. If they have a vision impairment, they may need plain language information. If there's an executive functioning or a cognitive disability, or sometimes that accommodation is they may need a place to lay down depending on what their disability is and how they're responding to the vaccine. Some sites are doing a really good job at this and some sites are not, admittedly. And then it's the accessibility, which is, I think, what most people are thinking about when they're thinking about barriers for people with disabilities. And that's, is it wheelchair accessible getting up to and through the site? It's the physical accessibility of the site and the location itself for people with disabilities. So seeing that we have this big data gap and recognizing the challenges in making sure that people with disabilities had an equitable shot at getting vaccine, my center launched a COVID-19 vaccine dashboard for people with disabilities in February. And we started out by just tracking the prioritization of the COVID-19 vaccine for people with disabilities across 4 groups, across all states, DC, and 5 US territories. And so we were tracking the prioritization of people in long-term care and nursing home settings and other congregate care settings, people with different chronic conditions, which can fall under the umbrella of disability, and then people that we put together in a group called additional disability groups. So people who are receiving direct support care in the community, people with intellectual and developmental disabilities, because at that time that was already a high-risk group based on the data we had, and people who were receiving certain Medicaid benefits. And at this point now, vaccine supply certainly has increased than when we started this project and is open to all adults in the United States. But in February, that certainly was not the case. And this was really sparked by one of my outstanding students, Sabrina Epstein, who is actually an undergrad at Hopkins, and had noted that there was huge disparities in how the disability community was being prioritized across states, again, despite the fact that we had a little bit of data showing the risk, and the interpretation of that across states was really not equitable. And it was a really interesting project, and over time it grew. So we made some visualizations. So what I'm showing on the slide here is maps, and they're all blue states now because every state is now open for vaccine across those categories that we track. Well, had been tracking, but we now track accessibility. So we are tracking website accessibility of information for vaccine, as well as registration for vaccine at the state level. And we're partnering with a group called WebAIM that helps us determine how accessible these websites are. And we get a score, and based on those scores, we're ranking the states. And I'm showing those rankings in a map form on the slide here. And then just this week, so we update, I should say that we update the dashboard every Wednesday, and have been doing so since February. And so just this week, we also added a component to adding a compendium or a one-stop shop for hotlines of how you can get more information about how to register for a vaccine or get information about a vaccine for each state. So we now list that on our dashboard as well. And we're tracking the accessibility of that. So for individuals with hearing loss or who are deaf, there needs to be what's called a TTY option. So we're tracking if that's available. I'm not showing it on this image. I'm showing a picture of our dashboard on the slide. We're also linking to the website itself and an email if that's makes that process more accessible to individuals. So through this process and through the pandemic, there's been a lot of national discussion around the barriers to information, to care, to vaccine for the disability community. And about a week ago, the Office for Civil Rights just released guidance to increase access to vaccine, COVID-19 vaccine for people with disabilities, which really is a landmark thing to have done, admittedly. And so what that guidance states is that all vaccine sites should be prohibiting discrimination, should be supplying reasonable modifications, and should be ensuring that there's effective communication. So let me be clear, this is intended to go a bit beyond the ADA and to make sure that communication strategies are reaching people that they need to reach, and that there is accessibility of the programs. So within this is discussions around transportation and helping people who are struggling with transportation in the disability community to get to vaccine sites. This was accompanied by the federal government's release of funds to support these efforts, which really, as I said, was a landmark thing to do. But the work certainly is not done. There's a lot we need to do and are working on, both in Maryland and at a national level. We are working hard to try and find ways to track COVID for this community. And I just want to say, you know, the groups I worry the most about are the groups that we don't often hear from. And those tend to be the most inequitably impacted. They are the multiply marginalized individuals, the BIPOC community with disabilities that is not plugged into healthcare. And how do we reach them, and how do we connect them with vaccine is still really remains a question. Thank you so much.
Thank you, Dr. Sweenor, for that excellent overview, a topic maybe we don't hear as much about as we need to. So I want to, a last presentation before our Q&A is Dr. Kaushar Talat. She is an assistant professor of international health in the School of Public Health and is an investigator in the Vaccine Research Center, and has been highly engaged in the COVID-19 vaccine trials. And she may answer many of your questions with her presentation. So, so we're going to have her start, and then after her, we will move into the Q&A. So Dr. Talat.
Thank you very much, Dr. Golden. I'm really happy to be here, and I listening to such amazing presentations that have gone before mine. I do hope my presentation answers some questions, and I'm happy to answer questions afterwards as well. So I'm just going to give a very brief update on the vaccines and vaccine safety, given all the news this week, and knowing that that may be some of the questions that people have right now. So I'm going to start by taking a step back and just talking about the two different kinds of vaccines that we have, even though we have 3 vaccines available, and how they work. So the first is the mRNA vaccines. These are the Pfizer and the Moderna vaccines. They are made of a small segment of the COVID virus, so just genetic material, so just the segment that codes for the spike protein. The mRNA for the spike protein is encased in lipid fat bubbles or lipid spheres. And these lipid spheres or fat bubbles, nanoparticles they're called, are nanolipids, sorry, are important because the lipids allow the RNA to enter the cells. In the cell, our DNA is kept in our nucleus. The cytoplasm is where all the work of the cell happens. And so the RNA enters the cell, and in the cytoplasm, it's taken up by ribosomes, which are the protein engines of the cells. And the ribosomes make the spike proteins. These spike proteins then are taken up by the cells of our immune system in the lymph nodes and in the blood, and trigger an immune response to the spike, which convinces our body that we've seen this virus before. And so we have a lot of antibodies to it. We have T cells against the virus, and we have, more importantly, memory. So this immune response can last for months and potentially even years, so that when our body encounters the COVID virus, the coronavirus, the immune system says, I know what this is, and recognize it and can attack it and prevent it from causing illness. Now, these vaccines are not live viruses. They don't have a whole SARS protein. They can't give you COVID. What they do is they have the body produce one of the proteins for the virus so that our immune system can respond to it. The other vaccine that is available is the viral vectored vaccines. This is how the Johnson & Johnson vaccine works. This is also how the AstraZeneca vaccine works, which is not yet available in the United States, but is available in many countries in the world, and is sort of the workhorse vaccine for the majority of the world. So they use a similar concept as the mRNA vaccines. They take a small piece of the genetic material of the COVID virus, the coronavirus. This time it's in a DNA form, and it's embedded inside of a carrier virus, an adenovirus. This adenovirus generally would cause colds, but it has been altered so it can't replicate inside of us. It's no longer living. It can no longer divide and cause disease, but what it can do is it can allow that genetic material of the COVID virus to enter into the cells. There, the cell has to take that DNA, make it into RNA, and then take the RNA and make it into proteins. But you end up with the same thing. You end up with the spike protein being made by our own cells, which is actually really good for inducing an immune response, because the immune response to that protein is much wider and much stronger than if we had given people the spike protein by itself. So we get the spike protein. The immune system can then respond to that spike protein, and when our body encounters the COVID virus, we know how to respond. The immune system can attack it, and we don't get sick. Now, these vaccines are very effective, but they do cause some side effects, and the side effects are very normal. There can be pain at the injection site, and that happens in most people. There can be some redness and swelling at the injection site, especially with the Moderna vaccine, tends to cause a little bit more redness. Fatigue, headache, muscle aches, and chills are quite common. Most of the side effects are worse after the second dose. For the 2-dose vaccines, the Pfizer and the Moderna vaccine, they happen after the first dose for the Johnson & Johnson vaccine, which is a single-dose vaccine. There's also some fever that especially happens after dose 2. Younger adults have more symptoms than older adults. And the reason for this is that when we're younger, our immune systems are more robust and so can respond more vigorously to the protein. And so as a side effect of that, you might have some more symptoms. However, as we get older, we found that these vaccines are still very effective, even though you may not have as many side effects. And so you can't just go by whether or not you have side effects after the vaccine to determine whether or not the vaccine is going to work for you or not. These vaccines are all incredibly effective and at preventing hospitalizations and disease. And so this is from 2 graphs from Israel, which was the first country to really vaccinate a large portion of its population. And here you can see the incidence of COVID infections, SARS-CoV-2 infections in the population that is vaccinated from the days after the first dose. And you can see really within less than 2 weeks after the first dose, so before they even got the second dose, the incidence of infections are really declining very, very quickly. So the 1 dose is pretty effective, although we don't know for how long. 2 doses is even more effective. And this is so this is the incidence of infections, and this is the effectiveness of the vaccine. And you can see within 2 weeks of vaccination, there's some good vaccine effectiveness that increases pretty strongly, so that by the time people got their second dose, the vaccine is 80% effective after 1 dose. And after the second dose, that goes up to closer to 95%. We have some real world data that's been released by the CDC on the effectiveness of the mRNA vaccines. We know that in the trials, the vaccines were 94 and 95% effective against preventing any illness and 100% effective against hospitalizations and death. This is a little bit different for the Johnson & Johnson vaccine that is a little bit less effective against preventing mild disease in the studies, but still 100% effective in the trial at preventing hospitalizations and deaths. Data in a trial is very helpful, but data from the real world is even more helpful. And so this is data from the CDC study where 4,000 healthcare workers, first responders and essential workers got the vaccines when were tested weekly for the virus. Now, this isn't being tested for illness. This is just being tested for the ability to carry the virus in their nose. And those who were fully vaccinated, so 2 weeks after their second dose of mRNA vaccine, were 90% less likely to have virus expressed in their nose. And so they were 90% less likely to be infected. We know that the vaccines are even more effective against preventing disease. And this is what Dr. Page showed the same slide, but that 2 doses of an mRNA vaccine reduced hospitalizations in adults age 65 and older by 94%, which is amazing because this is the population that's really been hit hard by this virus and by this pandemic. I'm going to switch gears now and talk about safety updates because there's been a lot of talk about the Johnson & Johnson vaccine in the news at the last couple of weeks, and especially this new syndrome that is just, we've just settled on a name and is just being described. So this is the thrombosis with thrombocytopenia syndrome. Thrombosis is a clot in a blood vessel, and these blood clots can block blood vessels and they can occur in the veins or in the arteries, and they can cause heart attacks or strokes. Thrombocytopenia refers to a low platelet count, and platelets are the cells that help form blood clots to stop bleeding. And the normal numbers of platelets in the blood are somewhere between 150 to 450,000 per microliter of blood. And thrombocytopenia occurs when the platelet counts drop, so to less than 150,000. This puts people at the increased risk of bleeding, especially if the platelet counts drop really, really low, so below 20,000 per microliter. You can have an increased risk of bleeding. What we have seen after the Johnson & Johnson vaccine is the occurrence of some very rare clots that happen in the veins of the brain. So this is a picture of the veins in the brain. This is and it's called the cerebral venous. And there's sinuses within this within the vein network. And so what we've seen in a few women after the Johnson & Johnson vaccine are clots or thromboses in these cerebral venous sinuses. And so this is an incredibly rapidly evolving situation. On April 12th, the CDC became aware of 6 cases of this very rare clots in the brain in women with low platelets after they received the Johnson & Johnson vaccine. And the following day, the CDC and the FDA decided to stop vaccinating with the Johnson & Johnson vaccine while they investigated and gathered more cases, informed physicians, healthcare workers, and the public about this very rare event to see how many more cases were out there, and to try to understand the risks of these events. So what the CDC and the FDA have found, they met again on April 23rd, and over the period of April 13th to April 23rd, they gathered a total of 15 cases of this thrombosis with thrombocytopenia, or TTS syndrome, that occurred in 8 million people who got a dose of the Johnson & Johnson vaccine. So this is about 2 people per million doses that were administered. These happened within 2 weeks after receiving the Johnson & Johnson vaccine. All of these 15 cases were women, 18 to less than 60 years of age. None of them were pregnant or postpartum. There was 1 case in a man in the Johnson & Johnson trial, but they hadn't seen it in men since then. This has also been seen with the AstraZeneca vaccine that has been licensed and used in Europe, and it is more common in women with that vaccine as well, although there have been some men who have been affected by this. This seems to be limited to the vaccines that use the adenovirus vector. There have been no cases of blood clots with low platelet count among more than 180 million people who received either the Pfizer or the Moderna vaccines in the United States. So well over 250 million doses of those vaccines have been given, and this signal has not been seen. After doing a very careful evaluation of the risks, these are more likely to occur in women. They're especially likely to occur in women, younger women. The peak age seems to be in the 30s. And the potential benefits of having a 3rd vaccine for people who are especially hard to reach with the mRNA vaccines, or having extra doses of a vaccine, or for other reasons, the CDC and the FDA recommended the use of the Johnson & Johnson vaccine resume because their modeling showed that thousands of hospitalizations and hundreds of lives will be saved by using this vaccine, but you just have to use it carefully. So this is a little bit more details about the women who had these clots. So the median age was 37, the range was 18 to 59. The median time to symptom onset was 8 days. That means that people had headaches, was the most common occurrence of symptoms, and occur. It's very normal to have headaches after vaccination in the day or two after vaccine, but they should go away within 2 days. So these are people whose headaches came back or developed for the first time from 6 days to 15 days out. And then it got progressively worse. Again, all were women. Some were in 12 out of the 15 had the cerebral venous sinus thrombosis, so it was in the brain. None were pregnant or postpartum, as I mentioned, and 2 of them had had a previous history of having COVID, and we know that there are some risk factors for clotting that it normally, and so these are some of the risk factors that the women had. But these are, like I said, very rare events. It's 7 per million cases in women under the age of 50. And the risk of being struck by lightning is 1 in 500,000 or 2 in a million. The risk of dying in a traffic accident at some point in your lifetime is almost 1 in 100 or 10,000 per 1 million. And we know that COVID illness by itself causes blood clots. So there's clots in COVID cases occur in 39 people out of 1 million cases of COVID disease. And these rare kinds of clots occur in about 3 people per million cases, where the clots in the vaccinated individuals with the Johnson & Johnson vaccine are 7 per 1 million women under the age of 50 who are vaccinated. And the clots that occur in the general population, these rare cerebral venous sinus thromboses, tend to occur at 5 per million cases. So in summary, and because of this, the vaccines, the CDC and the FDA do believe that the vaccines remain safe and do not cause severe adverse events for most people. There are risks and benefits to the vaccines, but the risk from COVID disease far outweigh any potential risk from the vaccine. So in summary, the vaccines are safe and effective way of protecting us and stopping the pandemic. Thrombosis and thrombocytopenia is a rare but serious and potentially life-threatening adverse event. We can potentially help prevent any severe disease by recognizing the symptoms that happen. They start 1 to 2 weeks after vaccination. It's important to recognize these symptoms and seek treatment early, because the treatment is a little bit different for this disease than for other clots because of the low platelets. And I think the thing that that gives me reassurance after this is that our vaccine safety system, surveillance system, is working. We were able to recognize this incredibly rare process with just 6 cases, and the CDC paused vaccination. We considered all of the cases and the risk, especially weighed the risks and benefits, and moved forward with a better understanding of the risks and benefits of these vaccines. And I'm going to stop here. If you have any questions, I'm happy to answer.
Great, thank you. That was a wonderful overview of the most hot off the presses information regarding vaccines. And I'm now going to ask if all of our panelists can turn their videos back on as we enter the Q&A. And so going to start, we have several questions that have arisen. So one question is from one of our audience members who a year after being testing positive still has a high antibody titer to COVID-19, and it seems like their own body is still producing antibodies. So the question is it safe to get the vaccine in that setting, and will it cause their own immune system and antibodies to sort of fight against itself, causing an autoimmune type of reaction?
So it is safe to get the vaccine in that setting. And we've given it to many, many people who have had COVID in the past. It won't cause an autoimmune process, but the vaccine, your first dose of vaccine will often act like the second dose in terms of how your body perceives it. Because you have antibodies there, because you have an immune response already, you might have more of those side effects after the first dose than what people normally experience after their second. And in some countries, they say if you've had COVID, then 1 dose of vaccine is enough because you get such a big boost with that first dose of vaccine in terms of immune responses. The CDC has not said that here in the United States, and we're still recommending that people get both doses of vaccine. The second dose isn't usually as bad as the first in that situation. But after a day or two, you'll feel fine and you shouldn't have any long-lasting problems from the vaccine.
Right, I think that may actually help to answer another question, because there was a question about someone who had a family member that had COVID, and so had a very bad reaction to the first shot, which is what you just described, because that's almost like it's their second shot in a sense, because the COVID was the first shot. So, but they're wondering with Moderna, should they get that second shot? And it sounds like in here we're still recommending that second shot, and likely that reaction will be much less.
It should be less. I mean, one thing you can do is wait. So the Moderna vaccine is 4 weeks out after vaccination. You can wait a few months if you want for the sort of the bloom of the immune response to decrease a little bit. It's not the right word, but yeah, you can absolutely get the second shot.
All right, great. So this is another important question for people to understand. Can you still get and transfer COVID if you've been fully vaccinated?
You can, so the vaccines aren't 100%. They are in the 95% range for preventing illness. So that means that some people will get COVID. It will make the disease milder than it might have been had you not been vaccinated. So instead of potentially, getting really sick or ending up in the hospital, you might have a cold for a few days. If you are ill with COVID, yes, you absolutely can spread it even if you've been vaccinated. What we don't really understand yet is if you have the virus in your nose, but you have no symptoms and you've been vaccinated, we think there's a theoretical risk you could transfer it, but we don't know how real that risk is. And that data that I showed you with the healthcare workers, they had a 90% decrease in their ability to carry the virus in their nose. So that's all very good news. But yes, unfortunately, it is still possible. We have very few vaccines that are 100% effective against preventing any illness, but it is still much better than getting COVID without the vaccine.
I think I would add, that's why it's important to still wear masks, because
Yes.
some people, when they're fully vaccinated, so I feel like throw caution to the wind. And so if you remember the slide that Dr. Usuro showed early on about the herd immunity, the reason to keep wearing the mask, even if you're fully vaccinated, is that chance that you could still bump into someone, pass on to someone who has not been vaccinated yet. And so therefore, keep that transmission going. So that's the reason to still be masking. And I think that's something important to think about until more and more of the population is vaccinated. So this is an interesting question about if you're fully vaccinated with say like the Pfizer or the Moderna vaccine, and then you get an antibody test that shows that you're negative for antibodies, does that mean that you're not protected?
Theoretically, if you receive the vaccine, the goal is to have an antibody titer that has been deemed by in vitro studies as immune. So there are a few people who are like immune non-responders. I had a friend growing up who got the MMR vaccine multiple times, and every time he got tested just didn't have titers. And so I don't know the data on immune non-responders for COVID, but if you got both vaccines but don't have the robust antibody response to prove that you have the titer, theoretically you're not immune to the COVID virus. And that's very interesting. I haven't looked into that data for that.
Yeah, and we have a much better sense. I agree with Dr. Usuro. We have a much better sense of what those protective titers are for other diseases. We haven't quite figured out what they are for COVID yet. But I think I would get another test because it might be a false negative.
Right, and I also think that one of the other things is, now it's almost a year when the first enrollees in the clinical trial started. It was around last June, and so I'm sure that this is the type of information that is being followed in the trial participants. So getting that information that we don't know about long term, and and responders versus non-responders and what that looks like. So hopefully there'll be more information coming out about that. So this is another good question. So if there's an adult who's fully vaccinated, but they have a small child who's not vaccinated, and we know that in the state of Maryland, it's 16 and over. So that means there's a large segment of our young people who are not vaccinated. Should they still stay distanced from them? And maybe in light of thinking about that you could potentially still be an asymptomatic carrier.
So I think that you're sharing your household with your child. And so you should continue to be careful. This is the reality for many of us, including myself, right? My husband and I are physicians, we're vaccinated, our kids are not. So we continue to be careful so that we don't inadvertently become infected, so we don't spread it to our children. And we ask our children to continue to be careful. So, we're not going into crowds unmasked or I see a lot of people eating inside of restaurants now. You'll just be careful, especially as the virus transmission starts to go down, that'll become safer and safer to do. But I'm not sure it's still a super safe thing if you have unvaccinated people in your household. I do know that the Pfizer filed for extension of their emergency use authorization down to age 12. And so hopefully within the next month, we'll be able to vaccinate kids as young as 12. But there's still the kids under 12 who it'll be much later this year before they have vaccine available.
And I guess just to clarify, I wasn't sure if the question was that whether the parents should distance from the children, because as Kausar said, many of us are in that situation. And so certainly, for my kids, we follow lots of precautions, like Kausar said, not going to crowded places, et cetera, et cetera. But within the household, at least, this is of course a risk benefit, but my sense is that, yeah, they're part of the household, and I don't distance with my kids within, we eat together, we do things together. That's a really important part of their social development. And so, and because I'm vaccinated and because we're taking so many precautions outside the house, I feel like the risk benefit, the risk of them getting COVID versus the risk of being completely isolated and all of us distance seems to weigh towards like us being together and having meals together and sharing our own household.
Yeah, and I would think, I would agree. I think that, one of the things to think about is probably still the highest risk areas for transmission are outside of the home, because there you are much less likely to know what people have been exposed to, who's vaccinated, who's not. And so I would be more concerned about protecting your children outside of the home as opposed to inside, because that's where they're most likely to be exposed and encounter more people. So hopefully that's helpful. There was a question about access to recording of this presentation. We will make it available, and the terrific team I work with will be able to email you and let you know where that will be. So we will do that so that you can have access to the information. So another question is, if you've had COVID, do you need to get the second shot? We answered that one earlier. So we talked about you might want to maybe space it out longer if you had the reaction from that first shot when you had it. And that's such an interesting question, because my son has a close friend who had COVID and then got the first shot and now feels fairly terrible. And so I was just explaining this to him not too long before this symposium. So this is another question. What if you have had if you're allergic to vaccines? And so some of you might want to address that, and I can tell you how that's addressing questions when you go to get the vaccine. But yes.
So the only true contraindication to vaccines are allergies. So anybody with any other underlying illness or underlying condition, including autoimmune diseases, it's okay to get the vaccine. The vaccines are very different than other compounds that we've used before. There's not a lot in them that you could potentially be allergic to. So if you've had an allergy to another vaccine, what we recommend is that you just be watched after your first dose for 30 minutes to make sure that you have no reaction to this vaccine. There is a compound called polyethylene glycol that's in Miralax, it's in Golightly, it's in some IV medications and vaccines that people people can be allergic to that's in the mRNA vaccines, and there's polysorbate, which is also in some IV medications that's in the Johnson & Johnson vaccine. So if you have an allergy to a different vaccine, I would still recommend getting vaccinated, but just wait unless you know that you have a specific allergy to polyethylene glycol. If you have a reaction to the first dose of an mRNA vaccine, then the recommendation is an immediate reaction, allergic reaction. Then the recommendation is not to get the second dose, but consider getting the Johnson & Johnson vaccine instead. And vice versa. If you have a reaction to the Johnson & Johnson vaccine, then any potential boosters in the future, you should consider getting a different kind of vaccine.
And I also want to add to that there was a really good, it was a small sample size, but if you have severe allergies and then there's any concern for the J&J vaccine, although it's been deemed quite safe and has been resumed, there was a small study that was published that under the care of an allergist, you can get small graded doses of that second dose. And those individuals who received it tolerated it very well. So if there's any concern for a response from the first vaccine, I would go under the care of an allergist or an immunologist and discuss whether you would qualify for potentially getting graded dosing for your second dose.
That's great. That's excellent. We alluded to this, and I think Dr. Talat, you may have addressed this in your presentation, but maybe might want to reiterate. So the question is, if you've already had COVID and presumably already have antibodies, what's the scientific reasoning behind still getting the vaccine? Because we typically haven't done that for other diseases. So what is it about the vaccine that gives the extra boost? Like, why would we do that?
So we know that people who have had COVID are less likely to get reinfected in the short term, but eventually, they do have a risk of getting another infection, another illness. And we think that the vaccine response to the immune response to the vaccine is better and different from the immune response to natural infection. And so we recommend that even people who've had COVID get a vaccine. Some countries are not doing that, but that's because they have far less vaccine supply than we do, and they're trying to save the vaccine for people who are at the highest risk. But we still do recommend that people who have COVID you could wait about 3 months and then get the vaccine.
All right, great. And so, this is maybe a question where perhaps we're going to need more long-term follow-up data. But the question is, how long after the Moderna and Pfizer vaccines can you still have a reaction? So, can you have reactions more than just that initial reaction that you get like after the second shot? So, long-term. Interested in your perspective on that. And
yeah, I'd like to hear from the other clinicians because they probably see more than I do. But I would say that usually the immediate reactions happen within the first few days. There's occasionally reactions that might happen, like the redness from the Moderna vaccine can happen 10 days out or 2 weeks out. More than a couple of weeks out, I don't think that you would expect to see any adverse reactions to the vaccines. But I think the other panelists may have more clinical experience.
There was, interestingly, when I looked into this, and if you look at all the vaccine data, going back from like 1796 when the first smallpox vaccine was created, there were plenty of reports that show that if you're going to have a long-term effect from any vaccine, you're going to see your effects within the first 6 to 8 weeks. And anything beyond that generally are no long-term effects from that. So if you have a rare case such as Guillain-Barré syndrome, transverse myelitis, something of those rare autoimmune components, you're going to see that effect within the first 8 weeks of getting your vaccine and not generally after that. And that's based on data since 1796, looking back at it. And so I think right now, if you look at the CDC and their VSafe data that they've recently published, just looking at people who've logged in and set their responses so far, it seems to be 2 weeks is kind of like that average point that people are starting to have effects. Again, the VSafe is for 2 years, so we'll continue to capture data for that. I'm sorry, it's for 1 year. We'll continue to get data from that. But so far, they've published that majority of the effects that people are having, they're at least noticing it and reporting it in a healthcare setting within 2 weeks.
And I think, again, as mentioned, you know, we'll sort of be approaching like the 1-year anniversary of enrolling in those initial trials. So then, you know, we'll have more of that long-term data to be able to answer those questions definitively, which I think is important. So this is a question about if you have an immune disorder such as Graves' disease or another immune disorder, can you still get the vaccine and will it work? I think the answer is yes. You know, if so, I don't know if there's any more elaboration to do, but that's a very common question though, so a good question, and the answer is yes, they will be effective in that setting. So this question is more of a scientific question about why have there been no animal trials in these vaccines to re-exposure to COVID-19 post-vaccine. So it's saying that in other previous FDA trials around vaccines that have been authorized to determine its effectiveness, you know, they will do the vaccine, give the animal the vaccine, and then they'll try to expose the animal to like whatever the infectious agent is to sort of evaluate effectiveness. And so just wondering if that has been done in this particular setting.
I'm pretty sure that they have been done for this setting. Yeah.
All the vaccines had preclinical animal trials in non-human primates and mice, and published it separately. But all three, Janssen, Moderna, and Pfizer, have all published their animal studies as well.
And that includes these challenge studies that you're mentioning.
So this is a question about long COVID symptoms, and we're coming in the home stretch. I think there's about 3 more questions. This is like one of 3 questions that were made. So this is about long COVID symptoms. So it's shortness of breath, daily headaches for about 9 months, nodules in the lung. And so what do we think about like sort of what is contributing to long COVID symptoms, especially in those who already have like high IgG titers, you know, and basically, will that help get rid of those symptoms? You know, and how do we have any information about maybe how the vaccine might impact long COVID symptoms? And I think that's probably an area of ongoing research, I think.
Yeah, absolutely. I'll let the other panelists answer about the long COVID symptoms itself, but we don't have the data yet, but I know that it is actively being investigated.
Yeah, I mean, I think what I would say is that we don't understand what it is exactly, although it is not an ongoing infection. That is clear. And, you know, we see post-infectious syndromes in other conditions, you know, totally different, but in terms not viral or not, like Lyme disease, et cetera. I think what has made us recognize perhaps this more than in other cases is that never in the history of the world did so many people get infected with one thing at the same time. And so that, you know, whereas before, you know, if a few people get infected with one thing, they may feel bad a year later, but they don't have any other person to compare with. The fact that, you know, hundreds of millions of people got infected really helped us recognize the syndrome. We still don't understand it. We know it's not an ongoing infection, but hopefully we will have, given that there's so many people and so much interest, hopefully we will have some solutions and better understanding soon.
I agree. And I would say that anecdotally, there was a report by CNN in early April that kind of followed a good handful, I think it was about 10 or 12 individuals with long haul COVID. And all of them, surprisingly, had improvement in their symptoms with vaccination. That's not standard amongst everyone, but it seems to be vaccination actually reduces their symptoms, if not eliminates it for most people. I know there are a few that are still experiencing, unfortunately, long haul, but reportedly, anecdotally, from the small cases, it does seem to improve.
All right, great. And this is a question related to our surveillance. So in the CDC's database, there are currently over 3,000 reported US deaths post-COVID-19 vaccination. So, you know, why is this not being discussed in the media along with the grade 4 side effects?
So VAERS is a fantastic database because it captures a lot of different kinds of data. It's a passive reporting system in that anybody can report to VAERS, and it doesn't link necessarily causality to to the event. It's just for data mining and gathering symptoms, gathering signals. We have other systems such as a vaccine safety data link that looks at both the numerator and the denominator. So like the number of events as well as what the base, how many people are vaccinated to better look at the causality. And the answer to that question is people die. People die of all sorts of things. And they can die a week before vaccination, or they can die a week after vaccination, and the vaccination may not have had anything to do with it. And so there is a team that looks at every single case of death that comes into the CDC VAERS report, but most of the time it's a heart attack, it's an infection, it's cancer, it's a car accident, it's all sorts of things, drug overdose. It's all sorts of things that may have that have absolutely nothing to do with the vaccine. And when you look at the systems that can look to see, are there more deaths reported after vaccination versus in people who are not vaccinated or in a control group? So the VSD, the Vaccine Safety Data Link, is better equipped to handle that. There is no increased rates of death. There's no increased heart attacks. There's no increased anything else that would lead to that. So yes, it is potentially, it is important to report everything that happens after somebody gets vaccinated to VAERS, but it doesn't necessarily mean that the vaccine caused it.
And I think in this one, we have time for just one more question. I think that, and to put it in perspective, we have now administered millions and millions and millions of doses of the vaccine. So 3,000 sounds like a lot, but we're talking millions and millions of Americans that have now received the vaccine. So just sort of helping to put some of that, into context, I think is helpful. And so this will be our last question in the interest of time. Very grateful for our panelists who either have to go and feed families, eat dinner for themselves, or do other things this evening. So this is a good question, since mRNA is more like an immune booster per se, the mRNA vaccines, that's how they work. Will it assist in preventing other viruses, or does it only target COVID-19? And so, the short answer is it only targets COVID-19. But I think what we've learned about this technology is that it is a powerful immune booster, as you said. So important to consider for other viruses. And I've heard that it's even being considered in cancer research and being used in other, sort of medical conditions. So I think that this is a technology that will have benefits beyond COVID-19. So we hope we were able to answer the majority of your questions. There are a couple of more remaining that we will try to type in a couple of quick answers to them. But we thank you for joining us this evening, and look forward to, we'll be hosting another event on May the 10th. So if you have family members or other community members that you believe would be beneficial, we'll be hosting another Q&A session, and then we will be hosting a session in Spanish on May the 3rd. Dr. Page will be one of the speakers, but just wanted to let you know about these other programs that we will be hosting. So we thank you for spending your evening with us, and stay safe and stay healthy, and wear your mask, wash your hands, and continue to practice safe social distancing. Thank you.